that. So multiple people have different.
Do it the top three.
Yeah, the top three was one. The biggest issue was that a lot of us had was the trial design. We won't even get to the experience of the trial design. The trial design automatically required you to get chemotherapy first. Many of us in the United States don't even give chemotherapy first because there's been no trial. In fact, there was a recent trial, EORTC 1205, randomized controlled trial, that just showed that there was no benefit to giving it before and or after. It's the same. It's a dealer's choice. However, Mars 2, they, based on their, what they were doing in the UK and in Europe, they decided both treatment arms were going to get chemo first and then get surgery. But we know off of literature and data that only about 20 to 30% of all mesothelioma patients actually respond well to chemo. It is generally speaking, don't respond that well to chemo. And we know these patients are already sickened because they have pleural effusions or they tend to be older or not as sick. And then you weaken them more with chemo. And then you do a big surgery on them. Not surprisingly already, they are going to do worse compared to just getting chemo. Right. And so what a lot of us said that we want to do, and in fact, David Waller has told this to Joel Dunning, and David Waller was one of the authors and one of the main surgeons in the Mars 2 trial, a prominent surgeon out of the UK, wants to do Mars 3. And ideally Mars 3, or what many of us in the United States would have liked to see, a fair comparison would have been you either get surgery followed by whatever, chemotherapy, all your next mix up first. So you're the strongest. That's when you can handle it. And then you give the chemotherapy, or you just give the chemotherapy and see. And I think a lot of us, which is what we do, many of us do is, often do surgery first, but we follow it up with chemotherapy. And that's what our guidelines really want. You need to get that systemic treatment in. But if you get the surgery in, first, how would those patients do versus just getting chemo? And a lot of us feel, and we've showed in, again, retrospective, so it's not a clinical trial. So it's, but we've showed multiple studies, Mount Sinai, MD Anderson, MSK, here at Kaiser, I'm forgetting some in Japan, that again, retrospective, not perfect, but patients that got surgery and systemic therapy versus just chemotherapy alone, or even with immunotherapy alone, the group that got a multimodal approach with surgery and some type of systemic treatment lived much longer than the group that didn't. And unfortunately, we don't have a randomized controlled trial looking at kind of apples, what we consider apples to apples and whatnot. So trial design was tough because a lot of those patients got weakened by chemotherapy and didn't have a good response. And right away, when you put them through a big operation after that, that already is an issue. That's number one. I know recorded, so it'll be like cut, right? Edit. So number two, kind of the issue was the extent of surgery complications was much higher. 30-day mortality, 30-day complication rate, and 90-day mortality were often 3 to 4 times higher than any other published big surgical literature with pleurectomy and decortication for mesothelioma. And for whatever reason, we don't really know, right? It's just, that's the data, right? But the mortality rates were 3 to 4 times higher. A 90-day mortality rate at 9%, meaning 1 in 10 of your patients were dead after surgery within 3